Good morning. Well, morning for me. This is chapter two. This should be, we're coming up to the end of week one in our X-ray curriculum. Chapter two of the Merrill's Atlas focuses on the lexicon or the terminology of radiographic positioning and general anatomy. So a lot of this overlaps some of the content you'll see in your structure and function course. And so it's 91 slides, so I'm going to go a bit fast through some of the anatomy stuff, not all the anatomy stuff. I'm going to pick up the pace and breeze over some of the slides because I know that you'll have similar content in your structure and function course. And then the other thing about chapter two and this positioning terminology is we're going to repeatedly use this. Like I said, it's a lexicon. We're going to use this language for the next year or so as you go through radiographic procedures 1, 2, 3, and 4. These terms keep coming back up. So I have high confidence that you'll adopt the lexicon eventually. That being said, you are going to be held accountable for chapter two's content for upcoming quizzes. So, but if you want to understand the x-ray text at the site when they say LAO or RPO or things of that nature, or tip the patient into Trendelenburg, or those kind of things, or proximal or distal or medial or lateral, you have to understand chapter two, the lexicon. So let's get into it here. So why is this important? What's the big idea here? The big idea is we use anatomy to describe proper positioning and proper setup of a projection. Okay, so an exam, taking an x-ray is really two things. You have to set up the image receptor in the x-ray tube in the right alignment to the body part, and then you have to position the body part in a certain obliquity or a certain orientation relative to the x-ray tube and the image receptor. Well, the way that we would describe this would be to use the anatomical language of the body part combined with some technical language about the process of taking an x-ray. Most notably, position and projection, which we'll get to probably about 3/4 of the way, 2/3 to 3/4 of the way through the lecture. We'll get to the difference between position and projection as far as radiography is concerned. And it's a very distinct difference, and I think it's one of the more important ideas coming out of this chapter is the difference between position and projection. And so I can guarantee you that you understanding those differences will be on an upcoming assessment. Okay, so we start with general anatomy, which you're going to also find in your structure and function class. Okay, most fundamental, we have planes of the human body, planes as in geometry planes. So like invisible or theoretical flat surfaces, two-dimensional surfaces with no depth to them that divide the bodies from certain orientations. So, and as you can see in this diagram, there's a sagittal, coronal, horizontal. Now the horizontal plane is often called the transverse plane in other texts because only when the patient is standing do we call it a horizontal plane. Okay? When the patient is lying down, it's no longer horizontal, it's vertical. So it's kind of a misnomer there. So occasionally I'll slip and call it a transverse plane. So right off the bat, there's two names for the horizontal plane. I'm more of a mathematical and geometrical purist, and so I call it the transverse plane because horizontal means running parallel to the horizon. in my mind. Okay, and that means it's always running the same way, regardless of whether the patient's standing or laying down. Okay, horizontal is always the same direction, right? So a little nuance, a little pet peeve of mine there. An oblique plane is any plane that is a rotation of one of the three standard planes. Okay, so that oblique plane that they're showing you is in fact a rotation of either the mid-sagittal plane or the mid-coronal plane, either one, because the coronal plane is a 90-degree rotation of the sagittal plane. All right. In addition to body planes, we're going to talk about the two major body cavities. We're going to talk about the divisions of the abdomen, both the quadrants and the regions. So there's anatomy has in its in the compilation of anatomy. Authors of yesteryear, one of them decided that dividing the abdomen into four corners was sufficient, and other medical authors decided that that was not sufficient, and 9 regions would be more appropriate for the abdomen. Okay. Surface landmarks are critical to your understanding of positioning because it's the surface landmarks and the palpable bony landmarks that you'll have to memorize to find your bearings, like reading a map of the human body. The iliac crest, the anterior superior iliac spine, the styloid process of the radius and ulna, the epicondyles of the distal humerus, the sternal notch, the vertebra prominens, the xiphoid process. All of these are examples of bony landmarks that can help you figure out where you are on the patient's anatomy, and that's critical for centering your X-ray projection correctly, is to align it with the appropriate anatomy. And so directions for centering are always given in reference to palpable landmarks. Right, so definitions of terms from the get-go. Anatomy is basically naming the structure of the body. So the body is built up of various components, various tissue types, various what we would call a singular structure, or in the case of the spine, a composite structure of many repeating singular structures. And these structures have components to them. So like a vertebral body always has a vertebrae rather always has a vertebral body. That's the ice cube shaped thing out front. And then use your imagination. Oh, imagination is critical in X-ray school. It also has, each vertebral body also has pedicles, lamina, and most of them, all except one, have a spinous process. Physiology is more functions of the body. So now that we've named the piece parts, now we have to understand processes and tasks that each organ does, that each tissue type does, that each body part does, so on and so forth. So we'll touch on that here and there, especially when it comes to pathology in the extremities. A lot of times physiology, that is the way that the upper arm moves and the way that you react to losing your balance, lends itself to a certain type of wrist fracture. And so the physiology will come into play as you understand how a Colles fracture comes to be. Okay. Physiology also comes into play when we get into Rad Procedures 3 and we're studying arthrograms, myelograms, and GI studies. So most of your fluoroscopic studies are in fact looking at physiology. Like how well can you swallow barium? Do you reflux the barium? Because if you do, you're probably refluxing your food as well. Um, are there any polyps in your colon? Does your colon spasm excessively? What's the travel time from the end of your stomach to the end of your small bowel? Because 2 hours is normal. Are you running fast? Are you running slow? Those type of questions are answered in some of our more advanced exams. And so physiology, we will discuss physiology with some of those examinations. And again, when we talk about common pathologies or common findings in the various examinations, physiology will be part of that discussion. Osteology, I'm giving you the definition here, but I've actually cut those slides from this lecture. So when you get to that part of chapter 2 in the reading, you can skip that section. You'll learn about that in structure and function class. So no need to repeat that lecture here. That saved us about 15 slides, I think. So, woohoo! All right. Body planes, getting back to the body planes that I introduced 3 slides ago or so. There are 4 fundamental planes, and again, they call that one horizontal when I would call it transverse. But either one is fine so long as you understand, even when the patient's laying down, the transverse plane is the horizontal plane, even though it's not horizontal anymore. There's a lot of talk about learning anatomy. There's anatomical position versus patient's current position. So this comes up most notably in pronated views of the hand and the wrist, and the ambiguity surrounding the terms medial and lateral. Medial and lateral we'll get into in a minute, or probably near the end of the lecture, relativistic terms. When discussion of anatomy occurs, you're going to assume the patient's always in an anatomic position, unless you've been specifically told they're not in anatomical position. Okay, I'll repeat that idea again so you can wrap your head around it. And this goes to right answers during a quiz question. So a certain quiz question is posed, and it's asking you about the relationship of one body part to another, so on and so on. You have to answer proximal or distal, medial or lateral, which are terms that will be coming up by the end of the lecture. But it doesn't tell you what position the patient's in. You know, are they standing in anatomic position or not? And the understanding, the unwritten understanding, the uncommunicated understanding is quiz questions are always referring to a body that's in anatomic position. Okay. The tricky part comes in is when we position for radiographs, we don't always put them in anatomic position. And so certain body motions to get to the correct position actually reverses some of those terms. In particular, the thumb, when we're discussing anatomic position, the thumb is most lateral. That is, it's furthest from the midline of the body, which is the definition of lateral in that context. So in anatomic position, the thumb is lateral. That is a true statement. However, when you're positioning for a PA hand, you pronate the hand, and now the thumb is medial because it's closer to the midline of the body, which is the definition of the word medial. Okay? That hasn't changed anything about the truth of the thumb in anatomic position. It's just acknowledging that this particular hand is not in anatomic position, and therefore the thumb is actually medial, closer to the midline of the body than the pinky finger is. The pinky finger is now lateral in a pronated view X-ray of the hand. Now, The tricky thing for you is Mr. Shepard disagrees with me on this point. But what I just defended and the relativistic definitions of medial and lateral is actually it's actually referenced in Merrill's Atlas, and so that's why I teach you that it is relativistic. It changes. The thumb does get closer to the midline when you pronate the hand, and so to call the thumb lateral is confusing because lateral means furthest from the midline. Okay, now that was a nice divergence. I'll touch on that again at the end of the lecture. Fundamental planes, sagittal, is the sagittal plane is the one that would go through a human body from front to back. So from the anterior side of the human body to the posterior. So the plane basically connects the belly button with the spine. So both of those, both the belly button and the spine, are in a sagittal plane, in the same sagittal plane. The special name for the middle sagittal plane that is halfway between your left and your right side is called the mid-sagittal plane. All planes parallel to the mid-sagittal plane are also sagittal, but there's only one mid-sagittal plane. And the same thing goes with coronal. Coronal planes pass through the body from the left side to the right side and the right side to the left. So both of your acromioclavicular joints, that is the joint at the top of your shoulder, the hard, you feel like a hard bump at the top of your shoulder, that's the acromion. And if you have a plane that connects your left and right acromion, that is a coronal plane. The mid-coronal plane is halfway between your anterior surface and your posterior surface. Okay. The third one, horizontal plane, only when you're standing up. The other name for it, as I've mentioned already twice, the transverse plane. Transverse plane is an accurate description regardless of whether the patient is standing or laying down. It's still a transverse plane. Okay. People are playing fast and loose with the term horizontal. I can't help that. I would like to correct them, but there's far more greater abuses of English going on than that. And then an oblique plane I already established was a rotation of any of the other planes is an oblique plane. Okay? And so we'll see axial planes, which are horizontal planes that are rotated. And then we'll see conventional oblique planes, which is either the sagittal or the coronal plane, which is rotated. All right, our sagittal planes pass, like I said previously, but here's a little visual description, from the front to the back. And so it divides the body into left and right parts. Okay. The mid-sagittal plane is a specific sagittal plane that's in the center between the left side and the right side. Okay. The mid-sagittal, understanding the mid-sagittal plane and where it is critical to your understanding of positioning. Most of our projections are AP or PA, and therefore those projections require us centering to the mid-sagittal plane typically, okay? Unless we're doing extremity work. But like if we're doing torso work, skull work, or spine work, we center to the mid-sagittal plane. Coronal planes are critical for lateral projections. They pass through the body vertically from side to side. That was the other plane on that previous slide, dividing the body into an anterior and a posterior. Again, there's a special mid-coronal plane, also called the mid-axillary plane, that passes through the midline and divides the anterior posterior into equal halves. Okay? And that's equal halves by distance, not by volume or weight. Horizontal planes are also called transverse. Axial planes, if they are oblique, we'll get into the definition of axials in a second. So if you oblique a horizontal or transverse plane, it becomes an axial plane. They're also called cross-sectional planes because our CT and our MRI machines default to the transverse plane to display slices of the anatomy. Horizontal planes give us the other component for centering for our position or projections in accordance with the various palpable landmarks. Horizontal planes or transverse planes are always perpendicular to sagittal planes and coronal planes. So a horizontal plane is a plane that divides the body into a superior portion and an inferior portion. Oblique planes divide the body part at an angle between the previous three planes. And typically axial is going to be a special case scenario of that. So typically when we're talking about oblique planes, it's usually a rotation of a sagittal or a coronal plane. All right, special body planes, these don't really, now the occlusal plane is an axial transverse plane, but there's a better way to define it and localize it. The occlusal plane is the bite plane. It is the junction of your upper and lower teeth. The interiliac plane is, most of the time, it's a transverse plane, unless you have a scoliosis or one leg longer or shorter than the other. The interiliac plane is important when we get to taking x-rays of the lumbar spine, and so that'll come back to us next spring around late February or early March. We'll be talking about the lumbar spine positioning, and we'll reference the interiliac plane at that point. Okay? Skip ahead to chapter 8 if you want to learn more. You just satisfy that curiosity anytime that you want to. Please satisfy your curiosity. We made you buy the books. You might as well explore them. You might even learn something. Okay. So there are two great cavities, the abdominal cavity and the thoracic cavity. I believe the anatomy book also talks about the neuro cavity, or maybe they call it the central nervous system cavity. I'm not sure. But they say that the brain and the spinal cord is also a great cavity. The Merrill's Atlas only identifies the thoracic and abdominal cavity. Abdominal cavity doesn't have a lower partition, but its lower section is called the pelvic cavity. So you'll see this in CT where they call it an abdominal pelvic cavity. We haven't really added anything. We're just acknowledging that the pelvic cavity is a subsection of the entire abdomen, I guess. So the thoracic cavity contains pleural membranes which surround the lungs themselves, the trachea, the esophagus, the pericardium, which is a separate membrane that surrounds the entire heart, and then the heart and the great vessels. There's also a thymus gland in the thoracic cavity, but we'll get to that when we talk about chest x-rays. The boundaries of the thoracic cavity are the rib cage, both laterally and superiorly, and the diaphragm. which runs underneath the lungs and the heart. Okay? The trachea only makes it about halfway through the thoracic cavity before it bifurcates into the main bronchi. The esophagus travels all the way through the mediastinum and actually penetrates the diaphragm. There's three major penetrations of the diaphragm: the esophagus, the aorta, and the inferior vena cava. I would say the spine too, but the spine actually runs posterior to the diaphragm. The diaphragm is anterior to the spinous structures. Our abdominal cavity, first and foremost, it's lined with a double-walled serous membrane that we'll learn about when we talk about decubitus views, and that's called the peritoneum. The peritoneum is a fluid capsule that surrounds your guts, basically. Your liver, your gallbladder, your pancreas, your spleen, your stomach, your intestines, your kidneys, your ureters, and your major blood vessels are all inside the peritoneum, with the exception of the kidneys. The kidneys are actually retroperitoneal. And so the kidneys are not, they're in the abdomen because they're at the same level of the abdomen, but technically they're behind or posterior to the abdomen cavity proper. I thought there was one other thing I was going to mention. Slips my mind now, maybe it'll come back to me. Right, our pelvic cavity contains the rectum, the urinary bladder, and parts of the reproductive system. It also contains the ureters and some. The aorta doesn't make it all the way to the pelvis. The aorta bifurcates into the iliac arteries, which bifurcates into the internal and external iliac, which bifurcates, or the external iliac becomes the femoral artery eventually. And that anatomy will become handy to you if you get into the interventional suite. We will talk about interventional radiography and rad procedures 4. That's volume 3 if you're curious, interventional radiography. So again, satisfy your curiosity. If you, interventional radiography is in volume 4. Yes, pause this lecture and go look to your heart's content. Be curious. I can't, curious? Be curious. I can't stress that enough. Okay. Divisions of the abdomen. Again, the diaphragm is the division between the thorax is superior to the diaphragm. The abdomen is inferior to the diaphragm. The pelvic inlet is the lowest point of the abdomen. And then the abdomen is subdivided into either quadrants or regions. And both of these are acceptable standard divisions. So we couldn't settle on one. That would be too easy. So you got to learn two different divisions of the abdomen. Okay. The first system is the quadrant system. Pretty straightforward. You just divide the abdomen into 4 corners: right upper, right lower, left upper, left lower. Couldn't be simpler. Now, the tricky thing about the quadrants, and something that you might encounter in a quiz question, is which organ lies in which quadrant. And so that's absolutely fair game. Now that I've mentioned it to you, like for example, you should know that your liver is in your right upper quadrant, your spleen is in your left upper quadrant. You see how I'm like pausing a little bit? I'm going to try to give you a chance to answer that yourself, and then I give you the answer with a 5-second pause. so that you can, you know, that's a little dopamine drip from me to you. It gives you a little boost of your, hey, I got that one right. Well, hopefully you got that one right. So yeah, you should look at the diagrams of the quadrants and look at the organs of the abdomen, and you should be able to identify if you're given the organ, which quadrant does it lie in. Now, here's your four quadrants, and here's your organ overlay. So you can see most of the liver is in the right upper quadrant. The stomach is mostly in the left upper quadrant. The spleen's not on here, but it's over there, lateral on the left side to the stomach in the left upper quadrant. See where the left armpit is? The spleen is in between the stomach and the left armpit, right up against the rib cage. In the right lower quadrant, that's where the appendix is, if you still have one. In the left lower quadrant is the sigmoid colon. And then the hepatic flexure is right upper quadrant. Splenic flexure is left upper quadrant. And that's the colon that I'm describing there. Okay. All right. So the regions of the abdomen, there are 9 regions, and the regions of the abdomen are not used as often as the quadrant system. And so there's a right hypochondrium, an epigastrum, and a left hypochondrium. Okay? In the middle, there's a right lateral, a left lateral, and an umbilical region. In the inferior regions, there's a right inguinal, left inguinal, and a hypogastrum. And I think, yes, there's a diagram for those. And again, the key would be to identify a particular organ in a particular section. Now, it looks like the middle sections are a bit bigger than, so where do you draw those lines? Typically, I would say that the appendix is in the right inguinal. If I had to guess, I would not, so the position of those blue horizontal lines on this diagram, it's a little relativistic. I would say that the rectum is definitely in the hypogastrum. I would definitely say that the pancreas is in the umbilical region. Okay. Some of the other organs, you see most of them like overlap, and they're in a couple of different regions, not just one. Maybe that's the reason we use the quadrant system more than the region system. But anyway, maybe a question about this too. But it'll be something obvious like the pancreas. Like I can definitively say the pancreas is in the umbilical region. And I can definitively say that the rectum is in the hypogastric region. So those are probably, if you do see a quiz question, that's probably it. But you should have, don't discount this and blow over it. You should study this because it's going to help you with your structure and function class anyway. All right, so here's our first review question. Which body plane passes from the body from anterior to posterior and divides the body into equal right and left halves? And so I'll give you a minute to look over your choices. Is it mid-sagittal, mid-coronal, mid-axillary, or mid-transverse? Okay. Now, passes through is a different direction than dividing the body into. Passes through means that's the direction the plane is oriented at. Dividing the body is what happens after the plane separates two sections of the body. Okay? So make sure you understand that nuance, that difference. And our right answer is, that is the mid-sagittal plane. It passes from anterior to posterior and divides the body into equal right and left halves. Okay? The coronal plane runs from left to right and divides it into an anterior and a posterior. See how we changed that around and it became, so if you reverse the description of plane passes through with divided into, if you reverse those descriptions, the right answer becomes the mid-coronal plane, which is a synonym for the mid-axillary plane. So if you understood that mid-coronal and mid-axillary were synonyms, you intuitively understood that that was not the right answer, because the question would then have two right answers. So mid-sagittal, as it's currently worded, is the right answer here. It passes through the body from posterior to anterior and divides the body into an equal left and right half. Right. Review question number 2. Which quadrant of the abdomen is the largest portion of the liver located? Okay. Where is your liver? Okay. Some of you will be relying on that thing on Friday and Saturday night, so might be important to understand where it is. Your liver is in your right upper quadrant. Okay. If you take your left hand and bend your elbow 90 degrees and bring your left hand across your midline and set it obliquely on your rib cage, you're right on top of your liver. You can find your gallbladder very easily if you are middle-aged. Then all you have to do is eat salad for 3 days and then try to eat a bacon double cheeseburger, and you will find your gallbladder quite effectively. And the middle-aged people will get that joke. The young folks, not so much. Surface landmarks. One of the more important slides. So if you've fallen asleep, wake yourself up and pay attention to this diagram. Okay. Now I've chopped off some of the labels, but I have this memorized. So the thyroid cartilage is at the level of C5. T1, T2 is right about at the sternal notch, sometimes called the jugular notch. T4 is at the sternal angle. T7 is halfway down the sternum, so halfway between our xiphoid process and our sternal notch is T7. T7 also corresponds to the inferior angle of the scapula. T7 is going to be critical to finding the midpoint, superior to inferior, of the thoracic cavity. And so we'll be using localization of T7 to position for our chest x-rays. Okay? So in preparation for learning a chest x-ray, you should memorize the level of the sternal notch, the level of the sternal angle, the level of the xiphoid, which is T9, T10, and the level of the inferior angle of the scapula. When we actually position for a PA chest, the inferior angle of the scapula will be the bony landmark that is most accessible to us, as the patient is going to be facing away from us as we position. Okay. Moving down into the abdomen, our second lecture is on abdominal positioning, and we need to know that the iliac crest is at the level of L4, L5. S1 is at the, and S2 is at the level of the ASIS, and the pubic symphysis and the greater trochanter are in the same transverse plane through the pelvis. I would recommend, if you have access to that picture electronically, copy it and paste it out and make it into a flashcard. If you need my assistance with that, technologically speaking, come see me and I can do that for you. I can make some flashcard printouts, but this is definitely a diagram that you should be memorizing straight away. All right, back after a short break. Oh, you should totally take one too. All right, body habitus. Not everyone is built exactly the same. Some of us are thicker, some of us are thinner. Well, what that actually does is it actually rearranges, in particular, the organs of the trunk. Okay, so you'll find that the asthenic people, which is the diagram on the right, asthenic habitus, the stomach sinks into the pelvis, whereas the sthenic habitus, the stomach is more horizontal and is higher up under the rib cage. Okay. And these two, it should be noted, these are the extremes of body habitus. There's some in-between body. There's 4 body habituses all in all that we recognize. But we need to be mindful of body habitus because body habitus determines, in a certain extent, determines centering and positioning, like for an upper GI, when you're trying to actually take a radiograph of the stomach. You have to know if it's likely to descend into the pelvis, because you would see the lime green highlighted organ there, that's the stomach. Depending upon the patient's body habitus, you would line up that shot and align the image receptor to the body 2 different ways to take those projections of the stomach. Okay. Positions of organs affected by body habitus: heart, lungs, diaphragm, stomach, colon, and the gallbladder. The heart is really, it's just vertical displacement. It sits a little bit higher in hypersthenic habitus. Lungs are a little bit longer in asthenic habitus. Lungs are broader in hypersthenic habitus. Okay. The diaphragm raises and lowers similar to the heart. In a hypersthenic habitus, the diaphragm is very high. The stomach we already saw on the previous slide. The colon also moves superiorly or inferiorly, depending upon habitus. And the gallbladder sits closer to the midline for asthenic habitus and sits closer to the right lateral rib cage for hypersthenic habitus. So these are our 4 major types. Sthenic means average, hyposthenic, slightly below average, asthenic is extremely below average, and hypersthenic is above average. Okay, so sthenic and hyposthenic, those are our more common habituses. That's our patients that we typically see are going to be in those 2 categories, but we will get some hypersthenic and asthenic patients, not as commonly, more common to see hypersthenic, and we will have to adjust the way we line up the x-ray for these extreme habituses, because the positioning guidelines are written for sthenic habitus. Okay. The differences in body habitus is outlined in the text. Oh, look, a broken shoulder. Okay. Skeletal divisions. Typically, we talk about the axial skeleton, which is the skeleton of the torso. And then the appendicular skeleton, that's the skeleton of the extremities. So the upper and lower extremities are appendicular. The axial skeleton is the trunk. I'm not sure how they classify the head exactly. We will make a point to dive into Chapter 2 in discussion on Friday and find that out. All right. Oh, look, how helpful and timely. So apparently the head is part of the axial skeleton because it's colored blue along with the rest of the axial skeleton. So the axial skeleton consists of the spinal column, the head, the rib cage, and the sternum. All right, bone features. Now this does dabble into a little bit of what you find in your structure and function book. But we do need to mention these structures, in particular the trabeculi, because we can see some of this stuff on the radiographs when we take them. So we'll be able to actually visualize an image critique, the difference between the compact bone, the spongy bone, the medullary cavity, and we'll be able to see epiphyseal lines. So you should be familiar with all these structures. You're going to get this lesson again in structure and function when you go over the skeletal system, but you should start understanding these structures, the bony trabeculi for the spongy bone, the compact bone, and as we get into image critique, you should be able to identify them not only from the diagrams, but also radiographically. So start learning these terms about the bones because these are the details that we'll want to see when we start doing extremity radiographs, like the fingers and hands. I think that's either week 3 or week 4. We're going to do fingers and hands x-rays, and we'll start looking for bony trabeculi and compact bone, medullary cavities, things of that nature. All right. Again, dabbling into structure and function. I won't quiz you on this slide. You will need to know what a medullary cavity is. It's in the middle of the diaphysis. That's usually where we say that the marrow resides, even though it resides in the middle of the trabeculi too. The central medullary cavity core definitely contains the bone marrow. Okay? Red marrow produces red and white blood cells. Yellow marrow stores fat cells. Okay? So your hematopoietic system, that's what this system is called, the system that makes your blood cells, is the bone marrow, and it's inside the bones. So your bones, not only do they support you and give you a physical form and make handy attachment points for the ends of muscles, but they also are involved in the production of the circulatory system, or at least the marrow tissue inside the bones is involved with the production of white and red blood cells, platelets also, and the blood plasma all come from bone marrow. Hematopoietic, that's the system that makes blood. It is the bone marrow, and that comes up in radiation protection radiobiology because that is one of the organ systems that fails with high doses of radiation. All right. So your periosteum, that's an outer membrane, and this actually, the primary purpose of the periosteum and the endosteum is to separate the bone matrix from the rest of the body, because the bone matrix is a great source of food for pathogenic organisms. And so having the periosteum and the endosteum basically shroud the bone matrix in a membrane, keeps it separated from the rest of the tissues. You do not want a bone infection. It is very, very painful. And not only that, but it actually starts to erode the physical bone tissue, and essentially it's like a microbial fracture. It's very, very debilitating as well as painful. So, and it's tough to get rid of a bone infection once you have one. So that's the role of the periosteum and the endosteum. And also they make the bone slippery so the muscles slide past. In particular, the periosteum has to be slick so that as you're flexing and extending your arms, your muscles, also wrapped in an outer membrane, also slick, slide past your bones without excessive friction. Okay? Membranes are very important. Without membranes that are constantly coated with slippery goo, you would tear apart your own body tissues every time you took a breath in. So, yay for membranes and fluid-filled spaces. So into the classifications of bones, I will be quizzing you about this: long, short, flat, irregular, and sesamoid. It'll probably be in terms of examples. And so I think I have that on the next few slides. Let's go into this is where I'm going a little bit more rapidly. All right, so long bones and short bones. Long bones are exactly what you would think, bones that are long. So the humerus, the femur, the tibia, the fibula, anything that's got a long axis to it in the extremity, the radius and ulna in the forearm, the clavicle, all of those are examples of long bones. Okay. Short bones are kind of pebble shaped. Okay, the carpal bones are good examples of short bones. Also the tarsal bones in the foot. Okay. Flat bones are two plates of contact bones. If long bones are long, then flat bones are, yes, flat. Well, mostly flat, because the skull, they're flat bones, but they're not flat. They're kind of rounded. But we still call them flat bones because they resemble the same structural makeup. It's like a bone sandwich. You have compact bone on the top and bottom, and then the middle layer is a thin, porous layer called diploe. Okay. We'll get to that when we get to the skull chapter in Rad Procedures 3. Remember that term, diploe. Okay. The sternum and the bones of the cranium, not necessarily the facial bones, but the bones of the cranium are flat bones. Okay. The scapula is also classified as a flat bone. Irregular bones are peculiarly shaped. It doesn't really fit into any of it's not a short bone, it's not a flat bone, it's not a long bone, it's an irregular bone. So the vertebrae and the facial bones are irregular. Also, I would probably say the three bones that make up the pelvis are also irregular. I'll let for that ring through. Okay, I think that's over. Sorry about that. What I was saying is the bones of the pelvis are also irregular bones. I know that on the recording there's going to be a telephone in the background. I do try to either stop or repeat myself if the phone rings while I'm making a recording. Sesamoid bones. I don't know why these aren't considered small bones or short bones, but anyway, they're their own classification. Sesamoid bones are they're small and oval, and they form inside tendons or beside tendons. So you always see sesamoid bones associated with joints, typically. Okay. Most people have two sesamoid bones on the ball of their foot, on the plantar surface of the ball of your foot. There's two sesamoid bones. The patella is a sesamoid bone. Unless you've had a total knee replacement, you have a patella out in front of your knee joint, and it's the largest sesamoid bone in the body. Inside and beside tendons, the patella is actually completely enveloped in your quadriceps tendon. Right, so your quadriceps, all four of your quadricep muscles turn into tendons just above the knee, and they wrap over the distal end of the femur, and then inside the tendon The tendon has an inner pocket that holds the patella, and it completely shrouds the patella like it was a bit of cheesecloth around a chunk of something. Okay? And then it tapers again, and then it finally tethers to the tibial tuberosity, okay, at the anterior side of the tibia. So the patella is actually inside the tendon for the quadriceps. Which of the following can be palpated to locate thoracic vertebrae number 7? Pause for dramatic effect and allow the students' brains to contemplate. Perhaps they're taking notes on the lecture and they can just review the last page because we did cover this just a little bit ago. The correct answer is what is called the inferior angle of the scapula. It's also referred to as the apex of the scapula, which kind of doesn't make sense because the apex is upside down. Typically you think of the apex as the uppermost point of a structure, like a mountain or a pointy roofed building. But the scapula's apex is the most inferior part of it. And it's also referred to as the inferior angle. And when the shoulder is relaxed, the inferior angle of the scapula is in alignment with thoracic vertebrae number 7. All right, arthrology. Arthrology? Yeah, okay. Yeah, the instructors do it too. They have trouble pronouncing these things too. It's been a while since I pronounced that one. So, study of joints. No, not those. I mean, the moving parts of your body. You know, the union of two bones. Not the funny cigarettes that your friend is trying to sell you. Okay. Classified 2 ways: functional and structural. And so we will be diving. This is also probably going to be duplicate material for structure and function. But we will be diving into this because so much of what we radiograph is related to joint spaces. Okay, so functional classification. The prefix, so this now takes us into medical terminology. Okay, arthro means joint. That's the base in all 3 of these words here. Arthro means joint. Okay, syn means without. Okay, oces means motion. Okay, so we have 3 parts to that first word: syn, arthro, oces. Okay, so it is literally saying a joint without motion. Okay, amphi means partially, like you learned in high school biology that an amphibian spends part of its time in the water and part of its time on land. So it means partial. Okay, there's arthro again, the base word, joint, and then there's osis again, which is movement. So this word broken apart says a partially movable joint. Okay, and then the prefix dia or die means complete, like diarrhea means complete running. Go ahead, look it up. That's what it means, complete running. Okay, or complete flow. I think that's an accurate description. Anyway, dia means complete. So we now have a joint that moves completely. All right, so one more time. A joint without motion, synarthrosis. A joint that partially moves, amphiarthrosis. And a joint that moves completely, diarthrosis. Okay, so all the people that are not in a medical background, when you say body joints, they immediately think of diarthrosis. They don't think of the sutures in your head. What? Yeah, the fusion of your frontal bone to your parietal bones is actually a synarthrotic joint. It's the union of two bones, but those bones are not supposed to move past each other, versus the bones in your finger are supposed to move past each other. And so the joints in your fingers are diarthrotic, but the joints in your skull are synarthrotic. And then amphiarthrotic, that is your pubic symphysis. All right, structural classifications. So we just did functional classifications. That was that previous slide. Now we're doing structural. There's a fibrous joint, that's the pubic symphysis, cartilaginous joints, and synovial joints. Okay. Now synovial joints have a fluid-filled membrane space. So all synovial joints are diarthrotic joints, because that's the point of having the fluid-filled synovial space, is to enable motion. Okay. Now, there's 11 specific types of joints in these three general categories: fibrous, cartilaginous, and synovial. All right, fibrous joints don't have a joint cavity. Okay. United by various fibrous and connective tissues and ligaments, strongest joints in the body. Three types: syndesmosis, which is this, syndesmosis is a fusion, okay, sutures, okay, and gomphosis. Okay. Syndesmosis are immovable or very slightly movable, united by fibrous sheets. The inferior tibiofibular joint is a syndesmosis joint. It's just a bundle of fibers holding the fibula to the tibia. Okay. A suture is an immovable joint in the skull, so the frontal bone is union with the parietal bone, or the parietal bone's union with the other parietal bone. You have a left and a right parietal bone. Those are sutures. Gomphomosis are immovable joints, you hope so, in the roots of the teeth. Okay. Using certain controlled substances may change the immovability of your teeth and the roots in the bones. Okay. Cartilaginous joints do not have a joint cavity. Symphysis and synchondrosis are, and they're virtually immovable. Okay. Cartilaginous. Why do I have a picture of a shark? Oh yeah, sharks don't have bones. They're all cartilage. So every bit of a shark is cartilaginous joints. Okay. Symphysis is slightly movable, separated by a pad of fibrocartilage. That's the pubic symphysis. Okay. Designed for strength and shock absorption. Okay. Synchondrosis is a movable joint. The epiphyseal plate is a synchondrosis. Okay. It's rigid cartilage that holds the ends of the bones together to the shaft of the bone. Synovial joints are what the lay people, what the general population thinks of when they think of body joints. They permit wide ranges of motion. They're freely movable. Some of them are complex and have many parts. They're enclosed by a membrane capsule called the articular capsule, or sometimes the synovial capsule. Many have accessory soft tissues, like the knee has menisci, and the shoulder and the knee both have bursa, where bursa are like additional membrane pouches that can add more fluid to the synovial cavity as needed for extra lubrication of the joint. Okay. Typically the bursa is activated with athletic activity. So when you're doing a lot of running or exercising or lifting weights or push-ups or whatever, and you keep doing repetitive motion with the joints, muscles around the bursa start squeezing on it, and the bursa, that's normally a reservoir of reserve fluid, starts emptying into the synovial space to increase lubrication, and it increases synovial pressure and actually makes the joint a little fuller and a little bit more stiff or rigid, so you don't accidentally injure yourself while you're overusing your joints. 6 types of synovial joints. Gliding, hinge. There's someone using the synovial joints of their hips and their knees right now. Oh, she could do more weight than that. What is one of those, 10s? Oh, that's a 5 kilogram. Come on. 2.2 pounds. Those are 12s. And then the bar, that's a mini bar. So it's a 15 bar. 15 plus 24, 30. She's doing about 40 pounds. That's nothing. She could stack another set of 5 kilograms on there. She could get it up to 50 pounds easy. Those are her quadriceps that she's using. It's the biggest muscle in her body. Okay? And women have actually more strength in their quadriceps typically than men do. So yeah, she's taking it easy. This is just a model posing for a real woman would actually put more weight on the bar. Just saying. Okay, back to the lecture. Gliding, hinge, pivot, ellipsoid, saddle, and ball and socket. Okay. The hips are ball and socket, by the way. The knees are hinge. Okay, so in the next few slides, I'm going to give you examples of each of these, and that's probably how the quiz questions are going to go. An example of a hinge joint is and then I'll list like 4 joints, and you'll have to say either knee or elbow, because those are basically, well, the interphalangeal joints of the fingers are also hinge joints too, but yeah. All right, so we start with the gliding joint. Gliding joint is the simplest synovial joint, and the motion is exactly what you expect. It is bones sliding past each other, okay? So intercarpal and intertarsal joints, your carpal bones, as you move your wrist around, ever so, it's not a grand motion, but there are subtle changes in the position of your carpal bones relative to each other as you like roll your wrist around or flex and extend your hand. Your carpal bones change position relative to each other ever so slightly. Okay. It's not a aggressive motion, it's a subtle motion. Hinge joints are more aggressive motions. Hinge joints are the classic joint motion. It is flexion and extension. Hinge joints work just like a door works. At either the joint opens up or it closes on itself. Okay. So notable examples are the elbow and the knee. I also mentioned the interphalangeal joints. Okay, that's above. So you know where your knuckles are. Those are called the metacarpal phalangeal joints. Just above those, where your skin is wrinkly on the back of your fingers, that's the proximal interphalangeal joint. And that is a hinge joint. You can only either bend that or straighten it. You can't like twist your finger halfway through. Well, you can if you grab hold of it with your other finger, but you might injure yourself, so don't do that maneuver. You don't have a muscle that can twist your finger sideways. You can only straighten it or bend it. Okay, so 2 motions, flexion, extension. All right, a pivot joint. That's how you answer the question, do you have your homework done? And typically you shake your head side to side. Well, what you're doing is you're pivoting C1 around C2. You see how the jokes come effortless to me? I didn't even break the lecture. Well, I did right now. I'm breaking the fourth wall now to tell you that that was just a joke. But yeah, shaking your head no is exercising the pivot joint, which is the C1, C2 inner space, okay? The atlantoaxial joint. Okay. Ellipsoidal joints allow for flexion, extension, abduction, adduction, and circumduction. You know that an ellipsoidal joint is ellipsoidal because you can trace an ellipse with the motion. Okay? So right now you could like hold your hand out with your fingertips extended and then try to trace an ellipse with the tips of your fingers. And as long as you don't have any pathogenic issues with your wrist, any arthritis or impingements or anything, you should find that you can approximate a pretty good ellipse with just, you keep your hand straight and it's just your wrist that's moving and you can trace an ellipse. Okay? The metacarpal phalangeal joints are also ellipse. So you can, literally the way I teach this to folks in demonstration is whoop-de-doo. So make the finger sign for whoop-de-doo. You have to spin your index finger and realize. So I say, hey class, did you know the metacarpal phalangeal joint is an ellipsoid joint? And then the class says, whoop-de-doo, Mr. Tillotson. And then they give me the little wagging, circling index finger. And the irony is you can't say whoop-de-doo with your finger and spin your index finger in an ellipsoid unless the metacarpal phalangeal joint was ellipsoidal. Not all the jokes are good. I apologize. I'm doing my best. I mean, this is some dry material, y'all. Okay. So our saddle joint allows movement similar to the ellipsoid. The difference is in the shape of the articular surfaces. Can you guess what the shape looks like? Yeah, they both look like saddles. Okay. Now, the easy thing to remember about the saddle joint is you only have two of them in the entire human body. The example that we give is the only example. There is only your left thumb and your right thumb, as they articulate with the wrist bone, the trapezium, forms a saddle joint. There are no other saddle joints in the human body. That's it. Just the carpal metacarpal joint for the first digit. Okay? So when I ask you about the saddle joints on a quiz, there should be no confusion. This is the only saddle joint. Really, there's no others. Ball and socket joint. Oh, look, here's some more humor. Only the old people will get this. Okay. So who is that? That is Pete Townsend, and that's his signature move. He would play, let's see, what has he got lined up there? Is that an E? It's been too long since I practiced guitar. Oh, it's not an E. Oh, he's got his pinky tucked. That might be like a G chord. It's either a C or a G chord. Anyway, he's holding his guitar pick over his head, and he made this on stage. He would make this big show of playing out a ringing, reverberating chord in the bridge to the song, and he would make these big windmill motions with his arm to do so. Okay, well, Pete Townsend was able to do that because his shoulder is a ball and socket joint. The ball and socket joint basically allows hemispheric motion. You can trace any point on a hemisphere with your arm. You can put your arm in any point on a hemisphere. You don't have to bend your elbow at all. Your shoulder can get your hand to any point on a hemisphere on that side of your body because the shoulder is a ball and socket joint. Now your hip, not as flexible, but the reason you can run is because your hip is a ball and socket joint. And if you can't run anymore, I'm talking about, a human being that's actually in shape. So no offense, and hey, I'm 51 years old. I can't run anymore either. That has more to do with me getting winded than the shape of my hips, but still. All right. So all the following are types of synovial joints. What was a synovial joint again? Well, which one of these is not a synovial joint? Syndesmosis is correct. Okay, the ellipsoid traces an ellipsoid motion. Synovial joints are ones that are filled with a fluid capsule. And that fluid capsule, the membranous fluid capsule, the synovial space, allows for free motion of the bones past each other. So ellipsoid, gliding, and pivot, those are all types of motions. Syndesmosis is a non-moving joint. Okay. All right, bone markings and features. We are an hour and 16 minutes and we're only halfway through. Good gravy. Okay. I would strongly recommend you stop this recording and pick it up another day if you've been listening thus far. Okay. I'm going to keep going, but you need to take a break. Cut this into smaller bite-sized pieces. So come back to this tomorrow. And welcome back. That was weird if you didn't actually quit, but okay. I'm just going to go with it. Bone markings and features. So we're going to talk about processes and projections, little lumps and bumps on the bones that are identifying landmarks and identifying structures. Okay. Now, in procedures class, you will cover the skeletal system, but you won't cover all the bony landmarks. You'll probably lean more into the physiology and the physical structure of the bones, osteophytes, osteocytes, things of that nature. Here we're going to learn more about anatomical landmarks and the parts of the bones, the processes and the projections, and we're going to learn about fractures because part of radiographic procedures is identifying the anatomy on the radiograph that you were intended to capture as part, so when you do a hand exam, you got to get all the bones of the hand on there. Okay, it's pretty straightforward, makes sense. When you do a chest x-ray, you have to get all the lung tissue on there, right? And so when we're doing radiographs of extremities, we want to be able to point out the anatomy and be able to recognize that indeed it is in the right position because the different parts of the bones will change positions. Some of them will be revealed, some of them will be superimposed on certain positions, and that's why we do another position is so that some of these processes and projections and little parts of the bones, the little sticking out parts, are areas that break very often too. And so it's important we learn the parts too so we can identify areas of fracture. Not that we're diagnosing for the patient, but maybe if we're writing an assessment for the radiologist. All right, so a condyle, here's the biggest condyles you have is in the distal femur. The condyle is a rounded process in our articular extremity. If your knee is thin enough, you don't have excess tissue around your knee, you can actually feel the femoral condyle by poking into just go to the side of your patella where there's a little tissue depression there, and if you poke back towards your hip, you should be able to feel the end of the femur. Okay, and that's you're palpating the condyle right there, the rounded articular surface. Okay, helps if you have the knee bent to do that. So in a sitting position, a coracoid or a coronoid process. Oh, that's awful. Those things are spelled so similarly. It would be terrible if you confused them on a quiz. Is a beak-like or crown-like process. A crest is a ridgeline. An epicondyle is a bump just beyond a condyle. So a condyle is a rounded articular process. An epicondyle is the bump just beyond the rounded articular process. And so now that you've found the condyle of your femur, work your way up past your patella and then go to either the inside or the outside of your legs, okay? And then push in and you should feel your femur again. But then as you walk up your thigh towards your hip, it kind of disappears and it's replaced by muscle. That edge, that last hard edge you can feel, that's the epicondyle of your femur. A crest that you can feel would be deep inside the love handle is the iliac crest, which is the top of your pelvis. Okay. There's epicondyles in your distal humerus on the medial and lateral side of your elbow. Coracoid process. I'm not sure if you have a palpable coracoid process. Maybe the mandible. So there's your TMJ joint's right in front of your ear. And if you hold your finger in front of your ear and wag your jaw open and closed, you can actually feel the TMJ joint move underneath you. Well, if you go forward of that, there's a coronoid process of the mandible, about an inch anterior to that. Okay. No, it's not your cheekbone, it's under your cheekbone. Okay. Facets, well, condyles are rounded articular extremity processes. Facets are flat or smooth surfaced. So facets are more in gliding joints, whereas condyles are more in hinge type and or ellipsoidal type joints. Okay. A hamulus is a hook-shaped process. The head of a bone is an expanded end of a long bone. Typically, it's the proximal end, but not always. The ulna is the exception to that one. A horn is a horn-like process, like a cornucopia horn. Look up cornucopia on Google. You'll see what I mean. The Fruit of the Loom basket. That's a cornucopia. Okay. What? Yeah, look at the Fruit of the Loom logo. God bless. Pay attention to details, people. All right. A line is a linear elevation, but not as prominent as a crest. Okay, so it's kind of subjective. A malleolus or malleolus, you can pronounce it either way. I like malleolus because then that's Latin, and then two of them are malleoli. Okay, so the square-shaped pasta that's got meat and cheese inside, that's ravioli. So an individual one would be a raviolus. Again, these are the best jokes I got, guys. Sorry. A protuberance is a projecting prominence that is not a condyle. And then a spine is a sharp process that is not a line or a crest. A styloid is a long pointed process, kind of like a styloid kind of looks like the tip of a nail. A trochanter is either of two large rounded and elevated processes of the proximal femur. So you only find trochanters at the proximal end of the femur by the hip. Tubercles, pausing, hang on. Sorry about that. It was an important phone call. All right. Yeah, tubercles are small, rounded, elevated processes. Tuberosities are large, rounded, elevated processes. So again, a little subjective, but luckily tubercles and tuberosities and trochanters are not on the same bones, and so we can partition them appropriately, and hopefully you won't get them confused. Okay. A fissure is a cleft or a deep groove. A foramen is a hole in a bone for transmission of vessels and nerves. A fossa is a pit, a fovea, or a hollow space. So it's like a little depression in the bone. We'll see those on the distal humerus, most notably the fossas. And then a groove we'll see on the proximal humerus is a shallow linear channel. The bicipital groove is at the proximal end of the humerus. A meatus is a tube-like passageway. The one you're probably most familiar with is the hole in your ear. An X-ray tech will call that the EAM, the external auditory meatus. Okay? It's just a tube-like passageway running through your temporal bone that houses the structures of the middle and inner ear. A notch is an indentation in the border of a bone. We'll see one of those in the scapula. Think like the back sights on a rifle, okay? That kind of notch, all right? And if you've never seen iron sights on the back of a rifle, this is Tennessee, for God's sakes, what are you doing? Sinuses. Sinuses are recessive grooves, cavities, or hollow spaces. The most notable sinuses, so yeah, those are the ones always getting infected. The sinuses, you have 4 sinuses in your face. Babies only have 3. The frontal sinus forms after you are born, okay? Which is the sinus of your forehead, which is one of the 2 that gets infected most often. The other one being the maxillary sinus, which is under your cheekbones. A sulcus is a furrow or trench. Sometimes a sulcus is like a foot, not like a human foot, like an amoeba foot, like a little outpouching. Okay. Types of fractures. Open compound. The bone is broken and the skin has been punctured. That's a open or compound fracture. We don't say compound fracture anymore because the public understands what compound fractures mean. And part of the reason for using medical jargon is to keep people calm. If they don't know what you're saying, they can't freak out. A compression fracture is a collapse of vertebral body. A open fracture is the bone is broken and the skin is punctured or penetrated. A simple fracture is opposite of an open or a compound fracture. Simples are also non-displaced. A green stick fracture happens with our pediatric patients. That is a fracture partially through the diaphysis, but not completely through the diaphysis. It's still a fracture, but it's not all the way through. Part of the diaphysis is still intact. Okay? Transverse fractures just deal with the orientation of the plane of the break. Spiral or oblique fractures are not they don't run transverse. Comminuted fractures are pulverized into many, many pieces. Usually a comminuted fracture is the result of a high energy injury like a car crash or falling from a great height. The bone, usually with low energy fractures, you usually just get either a transverse or a spiral. High energy yields a comminuted fracture. And then an impacted fracture is one in which the bone actually collapses on itself and one piece crushes into the other. Okay? Impacted fractures are usually, along with compression fractures, are usually secondary to osteoporosis. All right, so compression fractures, compound, comminuted, green stick, impacted, transverse, spiral, and simple. Many fractures fall into more than one category. Okay? Am I going to quiz you on, I'm going to say, yeah, what type of fracture involves the bone splintering into many, many pieces? And the right answer is comminuted. Okay? That means, yeah, pulverized into bits. You don't want a comminuted fracture, especially on a lower extremity. You end up having a loss of height as a result of a comminuted fracture to the lower extremity, potentially a loss of limb. Which of the following is defined? You like the picture of the, see, it's beak-like, right? So, picture of an owl. Just like cartilaginous involved a picture of a shark. See? I'm trying to, throw you some curveballs every now and then to keep you awake. All right, so which one is the beak-like or crown-like process? Okay. Is it a condyle? Is it a coronoid process? Is it an epicondyle? Is it a malleolus? Malleolus? Either one. It's not either of those. It's the coronoid process that is the beak-like. And the correct pronunciation, the words in red up there in the top right, say it like an English person, and it'll make sense. Harry Potter. Say, now you know what it says. Which of the following is defined as a hole in a bone for transmission of blood vessels and nerves? Is that a fissure, a groove, a sinus, or a foramen? It's kind of like low budget Jeopardy here. We have some lovely parting gifts for those of you that come in second place. It is a foramen. Anatomic relationship terms. Okay, anterior means toward the front. Posterior means toward the back. Okay, so your spine is always posterior. Thank you very much. The spine's always posterior. You won't believe how useful that piece of information will be when it comes to image critique. The spine is always posterior. Okay. Caudad refers to closer to the head end of the body. Cephalid, caudad means toward the tail end of the body. Okay, caudad literally means pertaining to the tail, even though human beings don't have a tail anymore. Caudad means away from the head, so toward the tail or toward the feet. Cephalid means toward the head. Sorry, I'm 65 slides in. That's my first mistake. Okay. Just listen to it again and look it up in the book so you don't get confused. Okay. So one more time. Cephalid means toward the head. So if we angle the x-ray beam toward the patient's head, that's called a central ray angle that is cephalid by so many degrees. Caudad means toward the feet. So if we angle the x-ray tube beam a certain degree toward the feet, like 10 degrees, 15 degrees, that's called a 15-degree caudal angle. A 15-degree cephalid angle would be 15 degrees off of perpendicular toward the head. Okay, we'll go through this in equipment manipulation lab, and we'll definitely keep reiterating this in positioning practice. Okay, we don't actually see an axial projection until I think it's the elbow when we first start seeing an axial projection. No, the wrist has an axial projection. So we'll see an axial projection when we get to the wrist. That'll be either week 4 or week 5 of the course. But I'll go over cephaloid caudate again when we do equipment manipulation practice. We're actually going to spend an entire day just figuring out how to move the X-ray tube and run the controls. Okay, anatomic relations, superior, inferior. Okay, these are not value judgments. These are directions. Superior means toward the head, okay, because typically the patient's head is up higher than their feet. Okay. Inferior means closer to the feet. Okay. Central means toward the middle. Could be either the entire body or toward the center of a particular organ. Okay. And then peripheral means on the perimeter or around the outside. Okay. Medial means toward the midline or toward the middle of the body. Lateral means away from the midline. Superficial means close to the surface. That's where ultrasound techs like to hang out. And deep, that means far beneath the surface where the ultrasound wand can't see. Distal means further from the point of attachment. Proximal means closer to the point of attachment. External means outside of the body. Internal means inside the body. Okay? We like to think of the bones as being internal. Sometimes the bones become external, and then that is a compound or open fracture situation. Parietal means perimeter or the lining of a body cavity. Visceral means pertaining to the organ. So when we go into the decubitus studies, and I think that's week 3, of the chest and the abdomen, we'll be talking about the pleura and the peritoneum. And both of those have a parietal membrane and a visceral membrane. Ipsilateral means on the same side of the body. Contralateral means on the opposite side of the body. A notable contralateral injury is a concussion. Typically, you will have brain bruising or swelling on the side of impact, but you also have a ricochet of the brain inside the skull, and the contralateral side will also experience tissue damage. Yeah, concussions are nasty. Palm refers to the palm of the hand. Plantar, plant your foot. You're standing on the sole of your foot, so the plantar surface is the bottom of your foot. The dorsum is opposite to the palm and the sole of your foot. Okay, so the dorsum is the top of the back of the hand or the top of the foot. Okay. Here we go. The most important slide of the whole lecture. If you've zoned out again, wake yourself up, stick your head in a bucket of ice water. This is really, really important. The definition of projection versus position. Projection refers to how does the X-ray beam pass through the body, from the X-ray tube through to the IR. What surface of the body does it enter and what does it exit? Okay. Position refers to how do we orient the patient while we're taking the X-ray, okay, relative to the image receptor. Do we lay them down on it with their back closest to the image receptor, well, then that would be supine. Okay, that's a position. The projection would be anterior posterior, or AP, because if the patient's laying down and the cassette is underneath them or inside the table, yeah, just wait, you'll see. The X-ray tube is positioned over the patient, and the beam comes down through the patient, entering their anterior surface and exiting their posterior surface. So all supine projections are AP projections. It's because X-rays travel in a straight line. We'll prove that in the geometry lab that we start. Okay. View is used to describe the body part as seen by the IR. View is a common parlance or common nomenclature in Europe, in particular the United Kingdom. Here in the United States, we prefer to talk about projections rather than views. Okay. And then finally, the method. A method is a radiographic projection that is named after the individual who dreamed it up. Okay. Typically, these are radiologists of yore. Now, what do I mean by yore? I mean the era, the 2 decades of practice when radiology was first formulated, which would be the 1900s and the 19-teens. Okay, so 1900 to about 1920, 1925. That's when we figured out how to take radiographs of the human body and what were the right positions for the patient so we could see certain characteristics in certain parts of the anatomy and could tell something about them. Okay. So your projections, AP, that means anterior posterior. Okay. The central ray enters the anterior, exits the posterior. PA means the opposite. Posterior, anterior. The central ray will enter the posterior of the patient and exit their anterior side. And then an axial projection is either cephalad or caudad, but it has to be an angle of 10 degrees or more. Okay, so a 5-degree angle is not really an axial. All right, ID the projection. Based on the definition of projection, which I said was the most important slide, just 3 slides ago, what projection is this? Excuse me. This is a PA projection. Okay. Yes, the patient is upright, but that is the body position. The projection is describing the path of the central ray indicated by the arrow. All right, let's try again to ID the projection. This is an AP. Now the patient is laying down on their back. That means they're supine in position. But I'm not asking about the position, I'm asking about the projection. I'm asking about the path of the central ray through the body. Okay? So yes, the patient is lying supine, but the projection is an AP, anterior to posterior. Okay? If you got confused by these 2 questions, go back and review the definitions one more time. It's critical that you wrap your head around the nuance between those 2. All right. Special projections. What if it's not anterior, posterior? What if it's left side, right side? Do we call it left side, right side? No, we call it a lateral. Okay. So if the central ray enters one side of the body and exits the other side and it passes through a transverse plane or a horizontal plane, then that's a lateral projection. A tangential projection is like, you have to remember geometry class, it skims along the edge of the body, intersecting at one particular point. Okay, kind of like a tangent to a circle. Okay, and then an oblique the central ray enters from a side angle, and typically that's accomplished by rolling or turning the body in the beam rather than moving the beam. Okay. All right, so the projection in question here. Take a look at that central ray, that little arrow. Yes, this is a tangential projection of the zygomatic arch is what is being shown here. Okay? Tangential projection of the zygomatic arch. We won't cover that one until Rad Procedures 3. Okay, IDing this projection here. Give you a moment. All right, the patient is standing up, but there is no option for upright, but it's not a position, it's a projection. So the central ray appears to be entering the left side, exiting the right side. And I said we don't call that a left-right or right-left. We just call that a lateral. This is a lateral projection. Looks like a lateral chest x-ray to me. All right, another projection here. Make sure you consider both of those diagrams. Okay. The perspective cues are key. All right, so he's laying prone, and that means, well, semi-prone. He's kind of turned a little bit. You can see the arm that's flexed. Which one is that? So this is where you got to use your imagination. Put yourself in his position. It looks like his right arm or his right side is in contact with the table, but his left shoulder is elevated off the table. Okay, so we would call that a oblique projection. He's actually oblique to the central ray, but the central ray is still mostly entering his posterior, exiting his anterior. So I would call this a PA oblique projection. Positions. Positions are body postures. Okay, upright, seated, recumbent, supine, and prone. Okay, so supine and prone are special subcategories of recumbent. Trendelenburg is it's actually a emergency position when the patient's blood pressure bottoms out. Put them in Trendelenburg so that blood can keep running to the head. Okay. The reason you have a blood pressure is so that the heart can force blood against gravity up into the head. But if your blood pressure drops, then you don't have enough force behind the blood and gravity drains all the blood from your head, and then you'll faint. You'll syncope, I believe is the medical term for that. So to avoid that, if your patient is suffering from shock, put them in Trendelenburg, all right? Head lower than their waist or lower than their heart. That's going to keep the blood up in the head, and it might make the difference between them losing consciousness and not. Okay? The Fowler position is the opposite of Trendelenburg. The Fowler position is the head elevated. Okay? Semi-Fowler's position is often called the lazy boy position because when you're in a recliner with your feet extended, you're in a semi-Fowler position. And then a Sims position, lying on your left side with your left leg extended and your right knee and thigh partially flexed. Okay? Sims position is also the recovery position for seizures. Lithotomy positions, that's for urography. It's typically there are stirrups, supports for the knees so that the knee is flexed, the hip is brought up, the thigh is brought up to a vertical, and then the knee is cradled in a stirrup. And this is typically done for uh, urinary stone surgeries and things of that nature. Okay. Um, a lateral position is named after the side of the patient closest to the image receptor. So typically when we do laterals, we're doing left laterals. If you ever do a right lateral, just indicate, be very specific, indicate, and make sure that the radiologist knows that you've done a right lateral rather than a left, because the anatomy presents slightly differently. There's some magnification effects and things of that nature, and it could be misinterpreted if the radiologist is not aware that it's a right lateral rather than a left. Oblique positions are named according to the corner of the body that's closest to the image receptor or the table. So those shorthands are RPO, LPO, RAO, and LAO. Those are going to be on the quiz. I guarantee it. Okay, so there's been 3 guarantees if you've been paying attention. This is the third one. Is there going to be another one? Well, we're running out of slides. I'm not sure. But an RPO, an LPO, an RAO, and an LAO, those stand for right posterior oblique, left posterior oblique, right anterior oblique, and left anterior oblique. Okay. Now, what is this person showing us? Looks like they're laying left side, left anterior, closest to the image receptor. So this is a PA oblique LAO position. Okay. It's a PA oblique because the patient's in an oblique posture. The central ray is entering their posterior, exiting their anterior. It's an LAO position because their left anterior is closest to the image receptor, which is tucked under the table. Decubitus positions. Okay. Decubitus means something different for an x-ray tech than it does a nurse. So if those of you who have experience on the nursing side of the house, you might have heard of decubitus ulcers. It's a different thing. Okay. Decubitus for us means lie them down and shoot with a horizontal x-ray beam. Okay. We'll learn about decubitus chest and abdomen positions in, like I said, either week 3 or week 4. Okay. And then lordotic position is the patient's upright but they're leaning back. And we'll also learn about that week 3 or week 4. All right, what's the projection here? What was the definition of projection? Oh yeah, it's the path of the central ray through the body. So the central ray, the little arrow, is entering their belly button. It's entering the anterior because your umbilicus is on the anterior surface, and it's exiting the posterior. So this is an AP projection. What is the position? Okay. Oh, and look, they identified the left and right shoulders of the patient, so you don't have to use your imagination as vividly. This is a left lateral decubitus. It's a left lateral decubitus because the patient is lying down on their left side, hence left lateral, and decubitus because they're lying down and we're shooting with a horizontal beam. Okay. So the nomenclature left lateral decubitus indicates the patient's laying on their left side and we're shooting with a horizontal beam. Okay. A dorsal decubitus means the patient's laying on their back and we're shooting with a horizontal beam. Abduction or adduction. Okay, those are opposite maneuvers. Abduct is to take away. Yes, very much like abducting a child. So as you draw an extremity away from the body, that's abduction. Okay? Adduction with the two D's is bringing the extremity closer in. Okay? So tucking is adduction. Extension is straightening a joint. Flexion is bending a joint. So these are all movement terminologies. Okay? Hyperextension is excessive extension. Okay? Typically, people can do this with their wrists fairly well. Other body parts, not so much. But most of us can hyperextend our wrist. Okay? Hyperflexion a little bit, but the wrist can also do that. Okay? Flexion would just be bending to 90 degrees. If you can go more than 90 degrees, then that's hyperflexion. Okay? Hyperflexion is what you can do with your elbow too. Don't do it too much, your bicep will cramp, trust me. Eversion and inversion, that's the rolling of the foot in and out by motions of the ankle and the tarsal bones. Hey, we're almost to the end. Pronation is rolling the forearm inward, so an internal rotation, so that the thumb is now medial and the palm is down. Supination is the opposite motion. Supination gets you into anatomic position. Okay? You externally rotate the forearm, the palm is up, and the thumb is lateral. Rotation is just turning of a body part. So supination and pronation are special types of rotation. Okay? So medial and lateral, or internal and external, are descriptors of rotation. Okay? Supination is a lateral rotation. Pronation is a medial rotation. Circumduction is circular movement of a limb. See the Pete Townsend slide when we covered ball and socket joints. Okay. Tilt is tipping or slanting of a body part. Typically the spine does this best. It tilts one side to the other. Okay. Not good for your posture and promotes early onset arthritis. Stop leaning, stop slouching, sit up straight. Deviation is turning away from the regular or standard course. Typically, deviation is done in the wrist, and we will learn that in week 4. We're going to do an ulnar deviation of the wrist for that axial projection. This looks like it's my last slide, so wow, 2 hours. Yeah, this is a killer. Hopefully you broke it up into multiple parts. I'm going to send out a warning to make sure that you do that as I upload this to the LMS Canvas. You guys have a good night. It's time for me to go home. Take care.